University of Maryland, and here to talk about their transitional service. Yes.
Hey, my name is Peter. Thank you so much for having me. Nice to see some familiar faces and unfamiliar faces, and it's been great to get back to my French. Sorry for being here. Nev got 9 Symposium accepted, which means that she is at every single Symposium block. And that's a lot, if only we all had such problems. And so she tried to offload a couple, and this is one of the few where her co-authors were present. So Sean and I were on the proposal that was accepted and felt capable of presenting the material. So Nev is not here. Hopefully she's asleep on the lawn or something like that, and she'll be back for the future presentations. But we're going to present, so this was a nice segue. We're going to present this development of the novel early psychosis discharge and transition navigation plan. And in many ways, it's actually, which I'll talk about very quickly, it's an attempt to kind of help people get to the point where they don't discharge in sort of like an unplannful or disorganized way, and that there is some communication with providers and with the team in general. I'm just going to present very briefly kind of the motivating context for this program, and then Sean is going to talk about the development process and how we've started to implement this program, which has been like a really kind of lived experience heavy process. So this shows in the United States really rates of different types of discharge. So this is a histogram. These are bar charts essentially, and it represents the proportion of people that had each of these outcomes. So all of these people are people that discharge. Now these people are they're all left at the end. And you can see that the most common category, the mono category, is completion, but that represents only about 30% of people who finish CSC in the United States, who finish early psychosis services. It is almost as common for people to unilaterally quit sort of like against medical advice. And it is very common for people to just simply lose contact with their team, which we have reason to believe is often just a form of quiet quitting, essentially, where you just kind of stop answering the phone, you're like, screw this, And then I want to also point out that there's a lot of categories in here that don't neatly fall under a good or a bad outcome. They're just sort of like a complex outcome, which I'm emphasizing because our intervention is intended to understand the complexity of human experience and not just simply be just we're going to get a little bus tokens or something, So, for example, transferred or moved is the third most common category. That's just like leaving the state, or in Baltimore, where people do have transportation difficulties. Maybe you move to the county, which is 30 minutes outside, it can be difficult. We also have some people who there's some obviously unpleasant outcomes like incarceration or death, but then there's also this pursuing positive opportunity. Some people leave CSC because they get jobs and they don't have time, or they go to school. That's happening this time of year in the CSC program that I work at. So they're just really complex categories, but it is not that common for people to simply complete our programs. And when they do discharge in the context of a completion, I find that often it's not as cliff-like. I'm very curious to compare notes on between our countries, because I wonder why. Often in Maryland, for example, people leave the program, but then in Johns Hopkins, they literally transition across the hall. It's literally across the hall, which is where they end up. At University of Maryland, where we work, people often keep their psychiatrists, and then the PRC people, we have many people who continue to see their therapists in private practice. People are really creative with keeping people involved. And our cutoffs for 2 years are not, they're supposed to be hard, but people often flub them a lot. There's a lot of predictors of different kinds of discharge. I regret including this slide. I'll just say that the predictors are different. So these outcomes all have really different profiles. And within themselves, they're also very different, right? So lost contact is something that seems like an unusually bad outcome in terms of the correlates. If we lose contact with you, you are less likely to be privately insured, which in the United States, unfortunately, is a really strong, almost one-to-one correlate of your family SES, your family socioeconomic status, not yours, but your parents, essentially. And you're more likely to be black, you're more likely to be male, slightly more likely to be unemployed, and higher negatives, etc. But some of the other categories don't have the same profiles that really was depend. Sorry about the slide, but I like it. I don't care if you don't like it. So this is outcomes by by self-reported symptoms. So on the far, that's left for you. So on the far left, so the raw data is in the back, right? But the teal line represents people who on the far left completed versus the red line where they did not complete. And you can see that symptoms tend to improve more for people who complete the program, and they tend to stay lower. So that teal line is the people who ended up completing, they tend to kind of improve more. But I want you to now look at the far right, which is unilateral termination, people who quit unilaterally. Their outcomes are just as good as the people who complete the program, and maybe better. It's not statistically significant. I shouldn't be like stalking, but they're not like, it's not like the profile of people that leave is like one of like disaster. Often people leave because they qualitatively because they feel good, they feel like they don't need this anymore, or they found something better, that kind of thing. Lost contact, though, you can see is not a great outcome. It seems like in terms of correlates. So people who we lose contact with tend, on average, not to improve at all, and they start high and they stay high. This is next stuff, and then how much time do we actually go?
Yeah, I think we're good.
Okay. Okay, so this is some of Nev's content. So she did that was quantitative, which is enabled by the EpiNet project, which is like now has this online portal, which I've already plugged, and I'm going to do it again. Please reach out to me if you want to analyze 6,000 early psychosis patients in America. We have people, in Denmark. We only in Canada. Those are the only two non-American countries, but we welcome anyone, and you can just reach out to me, and I'll try to work something out. But that was from that. But then Nev did this qualitative study. This was people in 2 different states. She interviewed 20 service users, family members, and community-based direct service staff, and she was purposely sampling for disengagement, people who had essentially left the program for one reason or another. There were a range of key themes, and she broke these down by like a provider, family members, and also clients. But I'm going to zoom in on the clients one because these are ultimately the people that are leading, So former and current clients, the kind of themes that came up in these 20 interviews for reasons why people left. I think going in, I did think it was going to be about as simple as bus tokens, to be honest. It is really hard to navigate around Baltimore. Like, it sucks. The bus system is bad. People regularly don't have cars, and it does affect things. I'm doing a clinical trial in Baltimore of DBT, and like the number one reason people don't come, if they don't come, is like my car broke down, or I just don't have a car, and then my mobile ride didn't show up. Like, those things really do happen a lot. But that's not what these clients are saying for the most part, or it's not what's most salient to them. People talk about not appreciating essentially how their providers talk to them, their providers not being willing to talk about their psychotic symptoms, not being willing to sort of like intimate the alternative explanations that people may have for their own symptoms. Like, for example, a lot of people complain about the use of the word psychosis or the use of the word schizophrenia, and we prefer things like voice hearing experiences or things like that. People talk a lot about, this is a major one that we see, we're continuing to do not research, but like we have lived experience panels where and this comes up a lot in those panels, where people were, what do we call it, committees or something?
Lived experience collective.
Collective, yeah. So people often feel coerced by their team, not just but especially psychiatrists, to be honest. Distrust medication, distrust their provider, feel coerced to take medication, feel like if they don't take medication, they essentially have to lie about it or they're being treatment. A subset have a really strong preference for peers in particular. And then beyond the clinic, feeling like people don't understand the sort of complexity of their world. Like it's too simple. Like you're giving me these like coping skills, and then I go back to this really difficult environment where again it's not as simple as like practicing breathing or something like that. That's kind of just some of the context is that we sort of perceive locally that like first of all, a major problem or phenomenon is that people are leaving, and then I think before completing, well before, and then also a lot of the problems seem to be like problems with the treatment model, in many ways, or with the treatment providers. So I'm going to pass it over to Sean, who will continue. Thank you.
Thank you, Peter. I need the mic because I move around a lot. Across the hall, I was behind the podium, but it was killing me. Peter, you got the clicker? Was there a clicker? There we go.
I think you like swipe up, kind of.
Oh,
it's a PowerPoint. Or a PDF.
There we go.
Yeah.
There we go, I got it. That works. Cool. So, essentially, I got involved with Nev and some of the team in Maryland and Pittsburgh, and we got funded for this program, which we identify with the project as the Project 2, but we've niched down more specifically a supported navigation team, and as it was originally sort of funded, it was more for the disengagement portion for people to get, hooked up with care for folks that were disengaging, but it's sort of that, but it's also a component of helping identify why people are leaving and help bridge gaps and understand what it could look like to find solutions to help people stay longer. So the solution was this supported navigation team, and essentially it has a counselor, a therapist, and a peer support specialist who have experience with early psychosis. For myself, I was a patient in one of the early intervention programs in Maryland a decade ago. It's from 16 to 19 years old, and now I train and consult the early intervention program peer support specialist for the last 2.5 years. So I'm one of the patient navigation coordinators as we're setting up the pilot. I'll get into that in a moment, but essentially this is something that will allow folks to have a neutral third party sort of problem solving and bridging gaps in between treatment and patients. And I'll speak to, as someone had said, having a team to rely on to dialogue when instances arise would work well. And the problem is sometimes that the way that this system can be set up, people end up feeling kind of not heard. And a lot of my journey, I talked earlier about, going off of naturopathic for the last 3 years after being affected by a medication lawsuit. Now that wasn't obviously in the first episode of clinic. However, I was not heard about my concerns with my psychiatric care with medications, and if I had a party like this that was able to help out in advocating when I was having concerns, and I'm a pretty confident person, but so imagine there's a lot of folks that are experiencing things and they're not able to really clearly speak up, and that's kind of what our goal here is with this. And like I said, this is a program for CSC participants, who have barriers to attendance. And ideally, it's also for family members who has loved ones that want to leave the program. Our goal is to troubleshoot, and provide community resources. We're also on the troubleshooting portion of it, finding out how can we troubleshoot in the future, how do we troubleshoot with family support interventions. We're not obviously there yet, as we're still just about to pilot this whole thing. But essentially, like I said, this is to troubleshoot and navigate participant concerns from a neutral place, and this really works in two different ways in benefiting both patients and their families and clinicians. You're obviously going to have groups of people that are already going to disengage anyway and are already going to leave. So for those folks, in the context of this symposium especially, we are setting up to ensure that those folks get taken care of, get transitional services into what might, find out how we could have improved and transition them to other services if they're so interested. And essentially on the other side of that, though, is for folks that are about to leave, maybe there's a way that we can intervene to keep people in programs that actually would want to be there if the solutions, if their problems were with not being heard or not being understood or not feeling safe enough in an environment to speak up, right? A lot of us don't feel safe enough to say, hey, I'm going through X, Y, Z, but the system is set up to show us that we're the patient and that is the doctor, and a lot of times, even though we talk about shared decision-making, it just doesn't always happen, right? And so this neutral third party is really what could help intervene in those difficult situations. And we can provide emotional support, right? Participants can talk about what, we can get to know the participants a bit better, as we're already doing in some of the lived experience collectives anyway. Obviously this is separate, but, with having that experience with psychosis and having people that are not affiliated with the program, but understand the program and are passionate about understanding psychosis and the experience of it, it really tends to, provide that emotional support while also bridging that gap and doing a little bit of both there. We can also help find supports in the community, right? If folks are disengaged, if people are leaving, if our participants are really dissatisfied, and they're really, it's such an entrenched problem with a particular clinician or a therapist, and they really just are really uncomfortable, or even if they're just like, hey, I'm good, or as they're approaching the end of their time in the CSC program anyway, we're going to be able to help in bridging that. This team is there to sort of link, as I talked about, link to services that could be beneficial for folks depending on what their needs are, right? And let me see, one second, make sure I cover everything. Sorry, usually I'm not a researcher in the traditional sense. I do a lot of advocacy, so all these slides are like a lot of information is a lot for me, so I apologize. So referral process, so far we've talked about having self-referrals where participants and families are informed about the service. Ideally, around intake, we haven't really sorted through as we're preparing to pilot, sort of sifting through and sort of taking it on a case-by-case basis, especially because different teams might want to operate differently, depending on what their needs are. Some teams might want it right at intake. Some teams might want it, want it relatively early, but not, everyone's going to do things differently, so we're still navigating what that could look like in terms of self-referrals, but ideally the situation will be that they know that we're there, and if they so choose, and in terms of having some sort of problem with things, they can know that they have a resource, an accessible resource to really be able to coordinate there. Team referrals, obviously, providers to talk to participants and families who they think will be interested and will benefit. And, timing, at regular intervals when the provider feels the time is right. And we're still open. This is still an ongoing thing. We're going to pilot, and there's going to be adjustments made after that as well. Family support. Ideally, like I talked about earlier, we'll have family support. We're seeking some input around families anyway. Families are obviously a big part of the CSC model and of recovery in general. I can definitely speak to that myself, having had a supportive family. It was made a big difference, right? We're here to offer troubleshooting. We're not here to be therapists. As much as I talked about emotional support, it's not in the way of replacing a provider, or it's essentially bridging gaps, making sure folks are heard, and advocating and keeping folks content with their treatment, whether that's discharging and releasing into a healthier program that meets them, or allowing them to go about discontinuing services altogether, or keeping folks in the program and really able to help bridge those gaps. So I think that's just about it. Does anyone have any questions? Sorry, I know I kind of ran through that. Yes, in the back. Go for it. Hold on.
Thank you for your presentation. I really enjoyed it. I was just hoping if you could speak some more about the concept that you talked about neutrality, like having a neutral space. And I wonder actually whether that almost sits in opposition whether that's even possible. Politically kind of, really problematic space, these spaces can be. So I'm just wondering what you meant by neutrality and how that will be achieved.
Awesome question. Oh, that's pretty loud. Sorry. Awesome question.
I'm having the same.
Okay. No, in terms of neutrality, I think the important thing is outlining boundaries early. And these are things that we're continuing to flush out right now, but outlining boundaries early in terms of we're here and we're hearing two sides of the story, right? We're hearing the patient's perspective of something. We're making it known through communication who we are and that we're not directly employed or affiliated with that program in that way, which is the neutral component to that, but also simultaneously we're here to, we're going to be hearing problems about the program, and I think this is a part of professional boundaries, clear, expectations of who we are as a team, and the continued clarification of that, because yes, you're absolutely right. It's not super black and white in this way, right? There's a lot of potential for gray area, and we want to make sure that we do our best to explain and, in the process of intake of what, and awareness of the program itself and the navigation team, we want to be as thorough in reminding folks on both sides, and whether it's the team or the patient's perspective, that we are here to help, but it is, at the same token, we're here to ensure that the patient is having a good experience, and if they're not, we're also there in the best interest of that, but if they are, or if there's a preventable thing, we're here to bridge that gap. So as long as it's clear, that's the goal, is to be as clear and thorough as possible. Hope that answers your question.
Very good response. Thank you. I just wanted to ask one quick question.
I'll go for it.
Just because I love university data and your graphs, but it's also kind of intriguing, isn't it, that some people that drop out of the service actually have as good outcomes as those that engage in the service. And I'm wondering if that's relevant, that actually maybe is there some thought about targeting your navigator goal to try and really access those people who are disengaged but really would then really benefit from being brought back in? So being a bit more assertive, I suppose, is going to be a target.
Yeah, so essentially finding those niches of pockets of people, and I think that the hard part of that, as we've seen from piloting, or preparing to pilot, has been sort of recruiting people that have already disengaged, to sort of understand why, because obviously some of them can be hard to track down, but in the meantime, absolutely going to be an important niche to cover in terms of as we're getting there and sort of getting these programs and allowing people to understand that we're there, finding ways to target that population especially, because that's the goal.
Yeah.
So, thank you.
Yes, another comment on that. We initially, there's a lot of iterations of this. It really has involved multiple iterations with lived experience council and the provider council as well. An initial iteration was we're going to try to reconnect those people that disengage. So our targets are going to be the people that leave treatment. That's not what we're planning anymore, in part because of those graphs that we saw. Some of the worst outcomes are when people who lose contact with the treatment team. And if you've lost, if they've changed their number on you, then you're not going to you're going to magically somehow we're going to be successful where they're not. And we know, clinicians aren't stupid. They're trying alternate numbers that are unknown. They're not trying. So we decided pretty early that we needed to catch people before they disengage in order to address disengagement in that way. If that helps.
University and the director of the Nova Scotia psychosis program to tell us what he's been up to.
Thanks so much. Obviously great to be here. It's such a great topic. And I think what you'll hear from me as well is